Hello, and welcome to a very special podcast that is part of a series I'm leading on diversity and inclusivity with CME Outfitters. Today's CMEO briefcast is entitled Achieving Equity in the Management of Chronic Pain, Treating the Whole Patient. Today's activity is supported by an educational grant from the Johnson & Johnson Institute and the Johnson & Johnson family of companies. I'm Dr. Monica Peak, and I'm a professor of medicine at the University of Chicago. I'd now like to welcome Dr. Jonathan Gorey.
Hi, how are you? My name is Jonathan Gorey. I am the director of the Chronic Pain Division at the University of Arkansas for Medical Sciences, and I am an associate professor of anesthesiology.
Thank you so much for joining us. I'm honored to have you with us today. I'm looking forward to this discussion.
Me too. Thank you so much for having me. Looking forward to a great conversation.
Excellent. Let me start with our first learning objective, which is to integrate strategies to provide equitable pain management for all patients. But first, we'll ask you, the audience, to give us your input on this question. Healthcare professional bias in pain care is most likely to cause which of the following healthcare disparities? A, up to 40% of people experience chronic pain. B, people of color are systematically undertreated for pain, regardless of socioeconomic status and access. C, disparate pain care is more prevalent in areas of high poverty, low education, and high public health insurance use. D, chronic pain is associated with obesity, type 2 diabetes, cardiovascular disease, and depression. And E, I have no idea. I'm not sure. So those are your 5 options. There's always the default to say you have no idea. And so we'll give a few minutes for the audience to respond, and let's see how we do. All right, so the correct answer is B, people of color are systematically undertreated for pain, regardless of socioeconomic status. And so we see that that is 43% of the response rate, so the highest number. So we're not quite at half, but it is the majority, the highest response rate. So we'll say that we're making a good start coming out the gate. So Dr. Gorey, as we just saw in this audience question, racially discordant pain care exists across medical fields and settings, regardless of SES and access to healthcare. Can you tell us a little bit more about the data on disparate pain care?
Yes, definitely. I appreciate that question. And I want to thank everyone for joining us, because this is a difficult topic, and I hopefully we'll have a good conversation. I look forward to your questions. You know, I think it's really important to talk about data, but I also want to talk about life experiences. And part of the reason that I went into pain medicine, I received naloxone when I was after a surgery where I was given too much fentanyl in the recovery room, and I experienced 10 out of 10 pain. And as I moved forward from that moment, one, I never forgot it, because when you experience 10 out of 10 pain, you never forget. But I realized, one, that there are patients who experience that level of pain every day of their life. And then two, that a lot of people who look like me, unfortunately, don't have the same access that I had to have their pain cared for that moment. And so I know that there are probably a lot of minorities, a lot of women, a lot of people who are in LGBTQ plus communities that are on this call who probably have experienced that feeling of having to almost armor up to go to the doctor, because you have to prepare to advocate for yourself or advocate for a family member. And so that's the experience. But then when we look at the data, and I don't think we have outstanding data, but the data that we do have does show that chronic pain is more prevalent in disadvantaged communities. And there are a few reasons for that. You know, some people may take that and think that there may be genetic differences or there may be other things, and we may talk about that later. But we have to look at the causes. You know, there's a lot of data that shows that African-American youth don't do as well on standardized tests. I'd argue that doesn't mean that there's an issue with intelligence. I'd argue there's an issue with where schools are, how schools are funded, et cetera. And that's the same with pain. So Poorly treated acute pain leads to higher rates of chronic pain. We know that acute pain is more poorly treated in disadvantaged communities. And there's lack of access to high quality care. Specialty offices aren't often in disadvantaged communities. And so it's harder to get those specialty appointments. And oftentimes, insurance coverage is not as good. And so you don't have access to what you need to prevent chronic pain.
That's a really good way of looking at this, not just from the medical perspective, but taking a step back and thinking about the similarities or parallels between this issue and other structural inequalities. So I think it's a really nice paradigm for all of us as we're thinking about structural racism and structural inequities, how they're very similar parallels in how we think about these issues manifesting within marginalized communities. Dr. Gort, you've done extensive research on the impact that this has in healthcare. And so what are some of the implications of disparate pain care in the lives of individuals and families?
Yeah, I think that's a really good question. And when I think about how this is brought to bear on some of these patients, I think about what I would call a broken social contract. And it's really between the Black community and all minority communities in medicine. And patients they come in their most desperate state. They lay to bear all of their secrets, all of their most intimate details to us, for us to be able to heal them. And historically, we've not done a very good job of that. And we haven't healed people. And to be quite frank, we've used that information to their disadvantage. And at times, we've left them worse off. And so we have a group of people who are asking to come to us to fix their problem, but we haven't done a good job of doing it historically. A restaurant gets two chances in my book. And if a restaurant gives me bad service twice, I'm probably not going back. And so part of it, I would say the burden is on us to try to fix that and we know that these communities have these problems. And when epidemics happen, pain epidemics, when we look at COVID-19 epidemic, when we have medical disease which affects a group, it often ends up affecting everyone. And so we need to make sure that we care for those who are disadvantaged. And I also throw out, there's an author who I love named John Sherman, who was at Duke, who I've gotten to know, who coined this phrase of John Henryism, this idea of fighting against the machine. And a lot of times people are fighting against the machine of racism, and that can cause health problems. And that ultimately led to John Henry's demise. And I would say that it causes disease in these communities that are often spending a lot of their mind share and a lot of their energy fighting an uphill battle. And while a lot of that research looks specifically at hypertension, I think there's a real parallel between that and chronic pain, especially when we think about the kind of work that a lot of these disadvantaged communities, people from lower socioeconomic classes have to do, doing construction, doing, being a mover, doing these kind of jobs where you're on your feet every day are really hard on your body and can lead to chronic pain. And all of this leads to a self-perpetuating cycle of damage, distrust, lack of care, worse outcomes, leading to more damage, distrust, and lack of outcomes.
Really important. We've already gotten a few questions that are asking about interventions and ways to best talk to patients, asking about social determinants of health. How do we talk to patients without using stigmatizing language, teaching medical students in a way that sort of debunks myths. And just for everyone who's putting these excellent questions in, I want you to know that Session 2, or Learning Objective 2, is really about action steps to mitigate disparity. So we're going to get to some of those, but keep bringing in the questions. And so we'll loop back specifically to those. One of the questions that came up is, what is the role of the pharmacist in identifying the undertreatment of pain in a patient?
Yeah, I love that question. And I think that we really don't do a good job of team-based medicine. And that, when we talk about broken contracts and broken relationships, that old school relationship between the doctor and the pharmacist, where they would call each other and discuss a patient's care, the pharmacist would notify the physician when something was wrong, is not really there anymore. And I think a lot of these issues are being are really being noticed at the pharmacy. And I think I love it when pharmacists give me a call. I know that probably sounds a little crazy, but a lot of times they're on the front lines, and I'm only seeing a short little snippet. I'm seeing 5-minute snippets of a patient's life, where the pharmacist is often seeing kind of a larger swath. And so a lot of the, I would say I'd put a plug in here for, working with local pharmacies, because I think they have a lot more time and they are able to build those relationships and able to pilot projects. But I think that the education piece is huge. And a lot of times pharmacists can really provide that education and empower patients to be their best advocate when they go back to the doctor. So even if they don't know that physician or can't call that physician, they can educate the patient on how to advocate for themselves.
Absolutely. Absolutely. Let's talk about pain care across the lifespan, because as you mentioned earlier, pain care disparities exist across the lifespan, including children from underrepresented minority backgrounds. So tell us more about this alarming form of disparate healthcare.
Yeah, I think this is so important for a couple of reasons. One, because this is when kind of that contract initially gets broken for each patient. And we all remember those days. We remember the best and the worst of times. Mm-hmm. We all remember that time we broke our arm when we were 7 and we were in the emergency room. Those are vivid memories. Secondly, the pediatric data is often, a lot of the confounders are removed of costs and insurance and other things. But when we look at pediatric data, I know that there is a slide on the screen showing a study looking at long bone fractures. Minority patients are often prescribed less opioids for the exact same pain complaint. This happens over and over and over again in the adult literature, in the pediatric literature. There's a study in JAMA Pediatrics that I often refer to that looked at over 1 million or almost 1 million patients who were diagnosed with acute appendicitis. In America, they were probably on their way to the operating room. And if they said they had severe pain, you were half as likely to get an opioid if you were Black. These are patients who are on their way to the operating room.
Right.
And so the challenge is, as this starts a very antagonistic relationship with medicine at a very young age, and perpetuates a cycle in which patients are undertreated, and then unfortunately, as they get older, can lead to either chronic pain or to a complete mistrust of the medical system.
Yeah, that perspective of sort of building blocks over time. A lot of times I think about this in terms of generational issues, but also the life course is really important too. Thank you for bringing that to us. So one of the best ways that we have to illustrate these issues, these structural and interpersonal inequities in pain care, is to look at the needs of individual patients and how inequitable pain care has affected them. So we're going to do a patient case. But before we do that, we're going to do some more audience-related questions. So the first is, or I guess the second question is, in acute or emergency pain care, what is the average ratio of white patients who receive pain medication for traumatic pain compared to Black patients? So is that A, 1 to 0.38, B, 1 to 0.59, C, 1 to 2, D, 2 to 3, and always available E, I'm not sure. So is it less than a 1-to-1 ratio? Is it a greater than 1-to-1 ratio? And then if so, where does that fall? And again, we're thinking whites to Blacks. So we'll give you a few minutes to respond. All right. So the correct answer is B, a 1 to about 0.6 ratio. But I will say that half the people realized that at least the ratio was 1 to less than 1. And so it's tricky. Who would know, really? 0.4, 0.6. So I give everyone, I'd say we were half right. I'd say 50%. And so to me, I think, that's an important number, but I think that the audience in general is on the right page. So let's go ahead and jump to our first patient case, Mr. Jamal Smith.
So yes, this is a 26-year-old African-American male. He's a graduate student, and he has a history of sickle cell disease and avascular necrosis of the hip joint, and he's awaiting a hip replacement in 1 month. He's currently on oxycodone 5 milligrams twice a day, and he presents to the emergency department with severe chest pain and debilitating hip pain. And at the emergency room, Mr. Smith is given his baseline dose of oxycodone 5, which does little to abate his severe pain. And this is a common story in patients, especially with sickle cell. And I think this gives us an opportunity to really talk about this disease and some of the disparities and challenges that this disease represents. And as I think about this disease from a macro standpoint, I think this disease really shows the importance of representation in medicine, and on more specifically, the importance of empathy. Because I think as physicians, and when we talk specifically about treatment of pain, or treatment of anything, we've all been in situations where we've either seen someone that is a friend of ours in the clinic, or we've seen a fellow physician and we've given them professional courtesy, or we've seen someone that reminds us of our mother or our child. And a lot of times those patients kind of get a little something special, right? You often overbook them. You may be a little more aggressive in their care. They may not have to wait for the next available appointment. And patients who are in minority communities often are less likely to be afforded this luxury because there are less physicians who look like their family, or who come from those communities, or who may be your neighbor. Mm-hmm. And sickle cell is a disease of minority communities, and more specifically, it's normally a disease of African American people. Yeah. And it's not for lack of knowledge. On the screen we have a lot of the statistics for sickle cell, but we learn about sickle cell in medical school. It's not a rare disease that no one's seen before. We know that it's a painful disease. When we're on our third year rotations, we are around patients who have sickle cell, and we see that they need pain care. Yet these patients come to the emergency department and are routinely labeled as drug seekers, despite our knowledge about the disease. Mm-hmm. And I think this also holds true when you look at the lack of progression and treatment options when it comes to this disease. The lack of research progression is that we haven't really made the strides in this disease as we have in other diseases like that are similar to sickle cell, other genetic diseases.
Right. And this is because these patients require chronic pain management throughout their life course. This is another opportunity where someone had mentioned the role of the pharmacist and and pharmacies, where there's so many neighborhood pharmacies. I hail from Chicago. I work on the south side of Chicago, where so many of our inpatient admissions are people with sickle cell disease and acute crises. And we have so many local pharmacies, Walgreens and CVS, and those are the main ones that are here. And when I go refill my own medicines, and the pharmacists there are members of the community. They're, advocating for, better health and really trying to educate the patients. And so those kinds of relationships are as important as physician relationships sometimes, and particularly for people who have chronic diseases and are managing their chronic pain. And so just underscoring that previous point and the one that you made about the role of pharmacists and pharmacies in the overall comprehensive care for people with chronic pain, because developing those trusting relationships where people can say, hey, I know Miss Jones, she's here for her, this is something that she has that is real, and she needs her pain medicine, or she's in a crisis. And understanding the humanity of people and where they're coming from plays a huge factor in mitigating bias and being able to maintain or not breach that trust that you were talking about.
100%. I agree. And I think as you talk about that, I begin to think about how, I've had patients who've been refused medications at pharmacies because they don't have that patient relationship with their pharmacist. And so I really think that's super important to build.
Mm-hmm, mm-hmm. So go ahead.
I was going to say, as we continue, I think another issue is acute pain inequities in the emergency department. And we've talked about that some already. Mm-hmm. And there's study after study that shows that. But I think one of the most important things to pick out from this case is this idea of acute on chronic pain. Mm-hmm. And patients who are on a steady pain regimen. And we have to then, they have breakthrough pain on top of that. And so, with this gentleman and with a lot of patients, they may be on opioids that are managed by a physician. And they come to the emergency room, and the thought process is, let's just give them the opioid that's been quote unquote working for them at home. If that opioid was working for them at home, they wouldn't be here. And so that's always a point to remember, is that whenever you have patients, or whenever we have patients who have a chronic pain issue, and they have a breakthrough pain, whether that be surgery, whether that be a sickle cell crisis, we have to make sure that they get their baseline regimen. And so even if they're on methadone, it doesn't matter what they're on, they need that. That's their baseline pain to keep them normal. And then we have to treat their breakthrough pain.
Mm-hmm. Yeah, that's an incredibly important issue. I think that a lot of times people are trying to calculate their home regimen and translate that into what we might be giving them IV in the hospital, but not necessarily increasing the amount. Yeah, it's really complicated. And thinking back about our patient case, the fact that Mr. Smith was a young adult, a person of color, and received ineffective pain care is often linked to implicit biases that stem from sociopolitical issues. So can you talk us through about the war on drugs and how we are previously treating the pain crises and opioids, and then how we're currently thinking about this? And what that means for patients who are getting caught in the crosshairs with sickle cell disease.
Yeah, I think that's a great question. And obviously it hits home because I'm a Black male, and I'd like to think that I'm young, even though I think that's changing. But as we think about historically, we've had a number of drug epidemics, and a lot of times when our response to those drug epidemics have been to limit or basically put in policy and police people who have drugs. I say policy, policing, and prohibition. Mm-hmm. And when we do that, we often use those tactics on disadvantaged communities more, and the people of means still have access to those drugs. So when we think about prohibition, that's what happened. When we think about issues with cocaine in the 80s, that's what happened. And when we look at opioids, we clearly are overprescribing opioids, and we've caused morbidity and mortality over the past 20 years. We have the highest rate of drug overdoses that we've ever had in the United States right now. It was just published by the New York Times and the CDC. But during that epidemic where we were overprescribing, we still had a group that was underprescribed, or multiple groups that were underprescribed. So as we reduce access to opioids, hopefully the worst case scenario is that we keep access the same for advantaged groups and reduce it for disadvantaged groups, which is what's happened historically during previous drug epidemics. But even a better case, which is still challenging, is that we reduce them equally. So then we take an undertreated group and we further undertreat them. And so we really have to look at, as we start to create policy, and as on a macro level, but also on a micro level, on our individual practices. And as we start to kind of make changes to account for the opioid epidemic, we have to make sure that we aren't unfairly, or that we're being equal, and we're ensuring that those disadvantaged patients are still getting the care that they need.
Mm-hmm. Excellent point. Excellent point. So do you want to wrap up the case?
Yeah, I'll wrap up the case. So for Mr. Jamal Smith, I think the big challenge that happened with him was that he was given the medicine that he took at home. And if that was working, he probably wouldn't be here because he had access to that in his medicine cabinet. And so when patients have acute pain crises, we have to be, the literature shows that we should be very aggressive with treating their acute pain, and that the actual risk of patients to opioid use disorder or poor outcomes due to opioids is actually prolonged use of opioids. It's using opioids too long, not giving too much in a one-time event. And so this patient's opioid tolerant. We need to make sure that we treat them appropriately. We listen to them. A lot of times, sickle cell patients have been to the emergency room multiple times for sickle cell crises, and they know what works. And we get a little scared when patients know how to speak the language, especially when it comes to chronic pain medicine. But these patients often can help you because they know what will work for what specific situation. And so this is a situation where listening, working with the patient can be extremely helpful.
Exactly. And I think your last point is really important. When patients tell us, oh, this one works and this one doesn't, that is usually a red flag that they're too savvy and that they're probably using drug-seeking behavior that's inappropriate, as opposed to, I've been, around this block a number of times. I know I have a good understanding of my pain tolerance and how to manage that, and taking a more collaborative approach. Let's move on to our next case. Our next patient is Miss Veronica Morales, who has a history of endometriosis. Maternal and reproductive health is marred by severe health disparities, as we've discussed in previous programs. So can you introduce us to this patient and walk us through her case?
Yes. So this is a 42-year-old Latinx female. She's a chef. She has a history of endometriosis. She's at hospital day one, status post a total abdominal hysterectomy. She has severe pain in her incision sites. English is her second language, but she repeatedly tells the nurses that she's in pain. And she's been prescribed morphine, but hasn't been receiving it despite her chronic pain. And this is unfortunately a common occurrence. And one of the challenges is that we know that bias influences healthcare decisions. And I often think of bias as especially implicit bias as information that we're using to make healthcare decisions that's not complete and sometimes is incorrect. And we know there's been studies that have shown that patients or physicians who have bias provide worse care. But I think as we begin to kind of dive into the data behind this case, or the thoughts behind this case, bias doesn't just stop at physicians, and healthcare doesn't just stop at physicians. And so oftentimes when a patient's in the hospital, they're encountering entire teams of people, not just physicians, but dietitians. They're encountering nurses. They're encountering nurse techs, front desk staff, housekeeping staff. They're encountering tons of people who help us provide medical care. And those biases can all impact care. When a physician writes an order for a medicine, they may be biased in their writing of that order. But then the delivery of that order is not normally done by a physician. It's normally done by other healthcare workers. And so if those healthcare workers oftentimes have to communicate with that patient has to be able to communicate that they're in pain, and then that nurse will have to then either communicate with the physician or provide a PRN medicine for that patient. And a lot of times that loop can be broken. And then when we get into, and I won't belabor those points, all of the mistrust issues, communication issues, kind of cultural issues that come into these conversations, a lot of times patients like this can unfortunately be left in a challenging position.
Yes, I have taken to like the term PRN. I almost never use that. I will say, patient can refuse, but offer it to the patient, because otherwise, patients oftentimes are not asking for it, or not asking for it in a way that somehow gets miscommunicated. They're not getting their medicines on a regular basis. And so the nurses aren't checking in the right way to say, are you in pain, even though they're there for a pain crisis, or they're there, with pain as a presenting symptom. And so their pain is getting undertreated. And so PRN pain medicines that aren't able to be self-delivered a lot of times is a setup for some broken feedback loops, as you said. One person who had a comment I thought was a great one, so I'll just mention it now, said she or he has had both nurses, residents, and other physicians complain that patients don't look like they're in pain, meaning that there's no sympathetic drive, and that they point out that the body acclimates to pain over time, and that the heart rate and blood pressure can stabilize. So someone may not have a very robust autonomic drive, but they can still be in pain because they have chronically acclimated to this painful experience. So that's an excellent point to make and to bring out.
Yeah, and I'll even take that a little bit further and say that some people have to control their emotions and control their sympathetic drive, because they don't get the opportunity to be angry when they're in certain situations. And so it sometimes it's a testament to what that patient has had to go through and the pain that they've had to endure, both physical and psychological, that they're not showing as much of a sympathetic drive as other patients. But we always have to remember that pain is a physiologic and a psychologic condition, and that's in the definition from the World Association of Pain.
Yes. What does it mean to be an aggressive or non-adherent patient? When might the police be called to intervene? And so, all of these things people have in the back of their minds when they're thinking about how they're behaving as patients. All right. So
I was going to say, we can go ahead and finish up this case. I think that with this patient, I think you gave one of the ideal answers for this patient. Is sometimes PRN medications, especially in patients who have language barriers or who English is not their first language, and they may not be able to communicate the pain that they're having, can be really challenging. And so making sure that you set up systems such that this patient can let the team know when they're having pain and also have their pain treated, because my fear for this patient is they're a setup for chronic pain as those kind of nerve endings don't heal, or they're chronically inflamed, that they may have issues later on.
Exactly. So let's, before we meet the next patient, poll the audience with a related question. So strategies that health institutions can implement to help reduce healthcare professional bias in pain care include A, the use of clinical guidelines, system-wide protocols, and standardized checklists. B, monitor pain management by social determinants of health, such as distance to a hospital and insurance status. C, apply drug monitoring scores to ensure a patient will not abuse pain medicines. D, implement training on the financial and health costs of prescription pain medication abuse. And E, I'm not sure. All right. Yes. We've had 66% with the first answer, and that is the correct answer. The use of clinical guidelines, system-wide protocols, and standardized checklists are a way that we can, as health institutions, implement strategies that help reduce healthcare professional bias in pain care. All right, so now we'll move on to our third patient, Dr. Ronald White, who's experienced disparate care for musculoskeletal pain and is also the victim of unfair drug monitoring systems. So please introduce us to, Mr. White.
So Mr. White is a 70-year-old African-American retired accountant, severe hip osteoarthritis and post-laminectomy syndrome. He's been prescribed opioids for 8 years at 80 oral morphine equivalents. He presents with severe pain. Another physician abruptly stopped prescribing pain medication. He's looking for a new provider. And the prescription drug monitoring database shows high scores due to doctor shopping over the past 3 months. And I think, I'll try to be a little quicker with this case in the interest of time. But I think there is a quote by Edward Demings that says that a bad system will beat a good person every time. And I think as we use prescription drug monitoring systems, I think that we all have good intentions. But at times, there are systemic issues with how Black patients access care. They oftentimes don't have access to specialists in their neighborhoods. There's the conversation about the mistrust or the damage they've encountered due to the system. And I often see patients a lot of times who see me in clinic and they've seen 3 or 4 other physicians and they feel like they haven't been heard, or that they've just been kind of, the physician talked at them or didn't really listen to their story. And so they've changed physicians looking for someone who will listen to them, not because they want medication. They just want to develop a patient-physician relationship that is based on caring, listening, and empathy. And so a lot of times in looking for that, you can easily be labeled as a doctor shopper. And so I think that we have to dig a little bit deeper in some of these situations to really understand, why has he had to change physicians? And then also in the time of COVID-19, I think there is another layer of health inequity, and that's really in the use of telemedicine. And I live in rural Arkansas, where a lot of my patients, I had not to pick on Chicago, but one of my colleagues at Rush, I had a conversation, and as we were switching to telemedicine, and he said, "Oh, it's easy. Everyone has an iPhone. Everyone has an iPhone." And I was like, "Not in Arkansas. I see flip phones all the time. Cricket is still alive down here." And so we have to make sure that as patients, as we switch to telemedicine, and patients have, there are some patients who have more access to me than they've ever had before, but some have even less. And so, we can probably wrap up this case, but I think, the challenge with this patient is to really listen and dig into the reasons that they have, had doctor shopping. We also need to dig into their access to subspecialty care. This patient had a bad outcome with a spine surgery. Certain communities are a little more apprehensive to having surgery. And so it may take a longer conversation to convince him to have his hip replaced, when a doctor probably told him that he'd have a spine surgery and he'd be back to normal, and he still has back pain. And so we have to sit down and kind of break through some of, what I would say is the onus is really on us to bring some of these patients back into the fold after we've, quite frankly, given them terrible service.
Yes, exactly. So in that vein, yes, let's talk a bit about some of these built-in biases for medical monitoring.
Yeah, and they're there, and that's probably what this patient experienced, is this idea that having to doctor shop, from patient to patient, having to doctor shop, or what we would label as doctor shop, to potentially find someone who would listen to them, who wouldn't just throw out and say, "You need a hip replacement." And then when he says no, not being willing to have that conversation, may set this patient up to be in a system that, may label them as doing something they're really not intentionally trying to do.
Mm-hmm. Exactly. So there's been a common thread in all of these cases of disparate pain care, and that they primarily stem from other healthcare disparities. What are some of the healthcare inequities that can lead to higher pain care needs?
Yes, minority patients don't have access to primary care. And so they're often or don't have as much access to primary care. And that can be due to insurance, that can be due to location. And so they're not able to have diseases diagnosed as easily. They have fewer access to specialists. They don't get referred as much. And that's something that we've looked into is referrals to physical therapy, and are they equitable? And oftentimes they don't get the same level of discussion. A lot of times when you really look at these visits, doctors kind of give orders to patients, to certain patients, but they actually explain the rationale behind that order, behind those orders to others. And I think we need to do a better job of making sure that our patients leave with an understanding and what I call buy-in to ensure that they then follow through. Because if you just write a prescription, tell someone to take it, you have to look into, can they afford it? Do they have access to that in their community? And all those different types of things. Are they going to have someone to take care of them when they get a surgery? All these things are important. And if you don't look at that whole package, you may just label someone as lost to follow-up or a non-responder or someone who isn't following through with what we asked them to do.
Yes. So thinking back about Mr. White, how can individuals in situations like these not be labeled as drug seekers with biased algorithms? What could we have done better?
I think we have to listen. And I'm sure that Mr. White has a story. And if we listen to his story, we may have a different outcome instead of looking at, I think that PDMPs are a tool. And I have been a part of the decision here in Arkansas to lobby to mandate PDMP checking for physicians here in our state. So I'm not saying that PDMPs shouldn't be used, but we have to remember they're a tool. And first of all, more than anything, we have to make sure that we listen to our patients.
Great. So we've talked a bit about the important issues of equities in pain care for their patients. Let's talk a bit about strategies to provide equitable pain management for all patients. What are some of the medical myths that should be addressed? And I know that there are a few questions that came up about addressing those in medical and nursing schools to help reduce healthcare biases. And what can we do to mitigate interpersonal and institutional biases in racism and pain care?
Yeah. I think the thing that I always try to remember is that pain is a mind and a body state, a mind and a brain state. Pain is a physiologic and a psychologic state. And that we have to also remember that not everyone's psychologic history is the same, and that trauma, depression, mistrust, all of those things, all of those factor into how a patient experiences pain. There are a lot of myths about how Black people are less sensitive to pain or have thicker skin or all these sorts of things that have been proven to be mistrue. But the challenge is that when people believe them, the studies show that they provide worse care. Mm-hmm. And so we need to ensure that our students and our residents who are coming out understand that a lot of these myths aren't true. And as we educate them, they will then begin to realize that those patients aren't different. So the care that they need aren't physiologically different. And so the care they need is not different from a physiologic standpoint.
Great.
I think this is a great paper. And when we talk about solutions, this is written by a good friend of mine, Natalie Strand, and I'm one of the co-authors of this paper, but it looks at what the pain medicine community can do to help with racism and implicit bias in pain care. And it really talks about how the onus is on us to put pressure kind of on education, on professional societies, on our own practice settings, and on the industry. And thankful that, this was sponsored by Johnson & Johnson, but, put pressure on industry to help because all have benefited and helped cause some of these inequities, benefited from and helped cause a lot of these inequities. And so we as physicians have to advocate for our patients to ensure that these solutions happen.
Exactly. Yes. And let's talk just briefly about patient-centered care and patient-centered pain care sort of nested in that broader construct before we wrap up.
Yeah, I wanted to touch on this really quickly. And so what's been shown in the literature is that when you have implicit bias towards a patient, that you actually talk more in the visit, the patient talks less, and your patient care visits are less patient-centered. And so the best way to counteract these biases is to know they exist. And so if you have not done implicit bias testing, the Project Implicit through Harvard is a great place to do that, to understand your own biases. Because if you know that you're biased against every single patient that wears a purple shirt, but you know that every time you see a patient walk into your office that's wearing a purple shirt, you'll think about those biases and you'll think about whether those biases are impacting your visit. And I promise you, it will change your care. And so going through and learning where your biases lie, and everyone has biases, we all do. That doesn't mean we're bad people. It means that we're human. But if we are ignorant to those biases and we cause care on our patients because of our ignorance, I would say that is our problem. So please, if you take anything from this conversation, go learn about your biases so that you can make sure that your care is equitable.
Excellent, excellent point. Just really beautifully articulated. Thank you so much for that. There's a lot going on in this slide. What I'm going to do in the interest of time is to just make that available. And we're going to wrap up and see if we might be able to take one or two questions. So I want to just thank you, Dr. Gorey, for this really insightful, inspiring, and helpful conversation on mitigating disparities in pain care. This was such a pleasure and so informative. To summarize our program, our SMART goals for each of us to keep in mind are: 1, to improve awareness of the prevalence and the impact of disparate pain care on patients from racially underserved backgrounds. 2, to identify and expand best practices to address structural and interpersonal racism that cause disparate pain management. 3, to provide trainee and healthcare professional education to counter false beliefs and biases that may be linked to inequitable pain care for patients. And last, to implement system-wide standardized checklists, clinical guidelines, pain assessment models, and scoring systems that eliminate healthcare professional and algorithm biases in pain treatment. So with that, I want to be able to maybe take one or two questions if we have time. So there was one question that, because this came up, we're sort of promoting the idea of guidelines and questions. And so someone asked, would it be more accurate to say that guidelines and checklists may mitigate physician bias without necessarily reducing it? And so I'm just going to toss that out to you and see what you have to say about that.
I think that is a fantastic way of saying how guidelines can be helpful, but they don't necessarily fix the problem. I think the true what we should do in healthcare is try to fix the bias. And I think that is going to be the solution. But if you don't have the ability to fix the bias, or you don't have buy-in to fix the bias, because you need hospital buy-in and physician buy-in to do that, then checklists can be helpful. And setting up systems that kind of mitigate the bias is the next best thing to do.
Excellent. Someone put in a question about one of our previous cases and said, often Latinx patients are more silent about pain or their medical history. And how do we handle this when we're trying to take care of patients in general and manage their pain?
Yeah, I think we do a very poor job of setting up patients for surgery. And while I'm a chronic pain physician, I also do surgery. I implant devices. And, I've talked to patients who say, I went into a hip surgery and the hip surgeon told me I wouldn't have pain. If I had pain, we'd take care of it. There's a much bigger conversation that needs to happen there. And a lot of it is like, you're going to have pain after surgery. We are going to cut you open. We're cutting your hip out and putting a metal one in. So when you have pain, it's okay to ask for pain medicine. And so we need to educate patients on their rights, what they should do, because a lot of times people in disadvantaged communities, and I'd specifically say the Latinx community, have been conditioned that they have been punished when they speak up. And so there may be situations where patients feel like it is going to be negatively impact my care if I tell the surgeon that I'm hurting, or I tell them that they didn't do a good job. And so we need to empower these patients to speak up. And that comes from us because we have the power. And so we have to, in our conversation, give them a little bit of that power, and so that this becomes a conversation and changes the dynamic.
Excellent point. Someone had a question about how do we interact with our colleagues who are, so let me just read the question. What is the best way to point out implicit or explicit biases to healthcare professional colleagues who may not feel that they are discriminating in pain care for patients?
Yeah, I think that's a $1 million question, a very hard question. I can talk about what we do. I'm fortunate that I am the leader of my division, so I can set the tone. I think it starts with the top. And so I think creating a safe space to discuss these things and normalizing conversation. And so we've done this with safety in hospital systems, right? So we've created morbidity and mortality conferences, safety huddles, see something, say something cultures around safety. And so we have to find a way to do the same thing around disparities and racism. And to be frank, a lot of other things about like sexual harassment, about all sorts of things. We need to create these cultures where it's okay to talk about them. And when we see things that, and sometimes physicians who are meaning well may do things that harm patients or harm their colleagues. And so we need to be able to open up and have conversations that are non-punitive. And at times they do need to be punitive when people are explicitly showing bias or harming a group. But I think normalizing those conversations is the most important piece. And having residents who rotate with me and being able to ask them, why did you say the patient's race when you presented them? How do you think that's going to affect their care? And just starting a conversation about it. Or do you think that patient had buy-in into our patient visit? Do you think we established rapport with that patient? Why or why not? And a lot of times race will come up, and then you begin to normalize that conversation. So if you're not able to with a colleague, maybe start with teaching, start with your conversations with nurses, start with your conversations with other colleagues. And at times you may be able to grow a culture that they may buy into.
Excellent. So I like the idea of all of that. Sort of bringing people into the fold, being an upstander, and creating cultural norms where we can sort of think about these as quality issues where the whole institution gets better. But we are out of time. I could talk to you for the rest of the day, but we can't. Thank you for your time with us. And thank you for the audience for staying with us. Please join me here at CME Outfitters for our upcoming briefcases and activities with more action steps against health disparities. In particular, 2 of our upcoming briefcases will examine diversity and inclusivity in 2 important areas, orthopedic care and cardiac arrhythmia care. We'll be adding new content on a regular basis. And so we want to hear from you, our listeners, about what's important to you so we can make sure that we stay updated and keep adding content that's important. To receive credit for today's activity, please complete the post-test and evaluation online. You'll be able to download and print your certificate immediately upon completion. And so I think that brings us to the end of today. Thank you all again so much for everything, and have a wonderful day and a wonderful holiday season. Thank you so much.